السلام عليكم.
عليكم السلام ورحمة الله.
عليكم السلام ورحمة الله وبركاته.
صباح الخير جميعا. طيب معلش أنا آسف تأخرت شوي، بس نبدأ بسم الله. شايفين السلايد؟
يس دكتور، بس لو تخليها على البرزنتيشن. يس ثانك يو.
طيب بسم الله والصلاة والسلام على رسول الله. طيب بسم الله والصلاة والسلام على رسول الله. Thank you very much everyone for coming. This is our fourth day of Pediatric Cardiac Surgery Review course. I'm Hani Mufti. Today we'll talk about ECMO, MCS, and heart transplant in pediatric patients. Okay, I want you guys to go to this website on your phones, on whatever, on the computer. Just write in the search box pollev.com. And then after that, you go to, you will have a page like this if you're using a computer, or a page like this if you're using your phone. I think the background now is black, it's not blue. And it will ask you join presentation. Just put Hani Mufti 557. If you join the presentation, it will ask you to put your name. You can skip if you don't want to put your name. Okay, and answer, please. Everyone got the answering page ولا لا؟ Okay, you can see some people are last year, some people are fourth year. طيب. Okay. Right. Okay, so next question will appear now. I'm sure most of you guys are residents. Just let's double check. Right. Next question. And this question is general, adult or pediatric. It doesn't matter if you see HeartMate or Berlin Heart or whatever. Okay, interesting. There's some people that have never seen it. Okay. Okay, fine. So, sorry, I skipped early. Okay, So have you seen a heart transplant? Good number of you have never seen a transplant. That's mainly not because just level, because there are not too many centers inside it that does cardiac transplant. Okay, next. Right. So some people can answer yes, some people can answer no. Okay, 50-50. Okay. So this question has to have or congenital adult or congenital MCS transplant fellowship. So if you want to do transplant MCS adult, I just want to know. Okay. Okay, fair enough. Okay, so the outline is quite a busy presentation, but it's a busy subject. So introduction, we'll start by talking about ECMO because it's the simplest and straightforward and most common form. Then we'll talk about shift gears to MCS, mechanical security support. And then we'll end up by talking about heart transplantation. So in John Gibbon is a surgeon who's in the early 20th century. Was one of the pioneers of cardiac surgery. So in 1951, he was working with Blalock, and because of the cross circulation and the complications that children were having by not being able to perform complex intracardiac congenital cardiac procedures, he was thinking, okay, why can't we develop a device that can do the job of the heart and the lungs? So he took 2 years sabbatical, went into the lab and just came up with the first heart-lung machine. And in 1953, this is the first case of a 5-year-old girl who underwent median stenotomy with on bypass to close an ASD. And as you guys can see, this is the heart-lung machine. This is the pump. This is the oxygenator, and the tubes are here. This is the ventilator, the old-fashioned ventilator. Anyway, so you guys can see how big is it, but this revolutionized cardiac surgery and medicine. So the question in any mechanical security support is a bridge to what? So a bridge, there are four common terminologies that you guys will hear in mechanical security support realms. With bridge to decision, which is the most common one. So it's either ECMO or short-term mechanical security support. Bridge to recovery, ECMO or short to medium-term mechanical security support. Bridge to bridge. This is basically a bridge to decision that went to bridge because the patient is recovering but needs more time. Or someone who went bridge to recovery, like a short-term MCS, and they are not doing well, and you can put them bridge to bridge as a short-term modality, or a bridge to transplant. These are the only 4 ones that people talk about. There's actually a 5th one that's bridge to death, but people don't like to talk about it. So sometimes to bridge to for death. So what is ECMO? So ECMO stands for extracorporeal membrane oxygenator. As you guys can see, the ELSO is the Extracorporeal Life Support Organization, which is the largest body in the world that controls or write guidelines and stuff for ECMO. It was established in 1990 by Dr. Bartlett, who was a congenital cardiac surgeon in Chicago. Sorry, not in Chicago, in Philadelphia. At that time, and in 1990 there were 86 cases registered in the ELSO registry of neonatal cardiac. And as you guys can see, with the improvement of ICU and congenital cardiac surgery, the numbers went up to 2008, and then they are still high, but not as fast as they are expected to go. For pediatric, for other pediatric cardiac, this is purely cardiac. Again, in 1990, 81 cases, and up to 2017, 780. These results are early in 2018, so they're not accurate. In 2018, the number of ECMO cases were 792. Adult cardiac is different. So the numbers were basically unheard of because of the complications, because people were not enthusiastic about ECMO at that time, and because ELSO was mainly governed by pediatric cardiac surgeons and congenital heart disease specialists at that time. So adult enthusiasm was not that high. But until 2008, and the peak was not mainly for cardiac, but the peak was mainly for respiratory, because in 2009 we had SARS and H1N1, and the intensive care specialists started to use VV ECMO more for respiratory failure, and the cardiac counterparts noticed that there is actually improvement of outcomes, so they're catching up. So why do we need ECMO? So basically, it is to do the function of the heart. So either the pump is failing and it needs to take a break for it to heal, or the filters that are after the pump are not working well and you need to give them a break for them to heal. And this is a nice depiction of what is an ECMO. Basically, it's a mechanical heart or a mechanical lung. So for respiratory ECMO, you know, on the left side, the figure shows the normal chest X-ray. On the right side, this is a patient with severe ARDS. So the lung is not working. You know, your filter is plugged, it's not working, it's dirty, it needs some time to clean. And you cannot take it out and clean it, but you need to give it time to heal. So you bypass it by putting ECMO. Now, this is another patient in the left figure with chest X-ray with cardiomegaly, acute decompensated heart failure. And on the right side, the echo shows severe left LV dilatation with poor LV function and septum bowing to the right side. So this is severe LV failure. And the pump is not working, the car is not starting. You need to give it a break so you can repair it. So this is a case, a real case, a 3 days old, 1.9 kilo premature baby delivered at the age of 29 weeks. Mother is diabetic. Apgar score was 3, 5, and 6, was in respiratory distress and got intubated, diagnosed as meconium aspiration. He's now on an oscillator on maximum ventilatory setting with saturation of 80% on an FiO2 of 100%. Now he has this. So he has bilateral, I don't know if the images are clear, but he has a bilateral pneumothorax. The ICU team cannot ventilate him, and after inserting bilateral chest tubes, bedside TE showed good biventricular function, no intracardiac anomalies, and this. So he has a large PDA with right to left shunt. What should you do? ECMO. So most people will say, okay, this is a baby that's dying. We need to do something about it. And we have ECMO, let's put him on ECMO. So the question now is ECMO, yeah, 29 weeks, no problem, ECMO. Get someone to put him on ECMO, but how? Okay, peripheral ECMO, but through what, which facet? So some people will say, okay, premature, we'll go through median stenotomy, but let's say that you're in an institution that does not have a cardiac surgeon, but have ECMO. There are some institutions in the world that has no cardiac surgery support, but they have pediatric surgeons and they have ECMO support. So in neonates and children less than the weight of 6 kilos, it's almost impossible to get the femoral veins because they are very tiny. So the common approach is the right IJ and right carotid. But then some people will look at your right carotid. What about the brain? It's okay. It's okay to go through the right carotid because the circle of Willis is patent. There is no calcification. The baby did not have time to develop any calcification. And the brain can adapt very easily. Now the question is, but why do we need VA ECMO for a patient that has a normal heart? Again, because there is no access for VV ECMO unless you go centrally. Basically, you do total right-sided bypass. But then there's no point of opening someone just to do VV ECMO when you can do VA ECMO with very minimal complications. Is this clear? Because this is a very common question. People struggle to understand this part. شو داخلين اختبار عن هنوف ومحمد جلال وفيصل وعبد العزيز. واضحة النقطة دي؟ والجميع طبعا بس
Doctor, how about IJ and femoral vein? Femoral.
In a baby, I just said it a couple of minutes ago, but in a baby that is less than 6 kilos, the femoral vein is around 4 French. Believe me, you do cut down, you barely can see a vessel that you can put a regular 21 French cannula, 21 cannula in. So the vessels are very small, so you cannot put a cannula enough to drain or return blood back into the heart. That's why it's almost impossible. Some people have done iliac vein, common iliac vein cannulation, but then you have to open the abdomen, and it's a nasty scar, and the benefit is very minimal compared to the risk that you can injure bowel, you can injure the kidney, you can injure the bladder. So, and VA ECMO is very, very safe in neonates.
Up to what weight is this the case, Dr. Han?
Most people will say, there is no hard written rule, but most people will say 5 to 6 kilos is it's almost impossible to cannulate the femoral veins. Around 10 kilos you can, but I'll talk about it. But in a child who's not walking, and usually the age that they start walking is at around 8 kilos to 10 kilos. The femoral vessels are very small, so you have to reverse if you do VV ECMO at around 10 to 12 kilos, you have to reverse your circuit. So instead of your drainage being from the femorals, you actually have to put the smaller cannula in the groin, and you have to do your drainage from the neck and return into the femoral vein. And that's mainly because of vessel size and cannula that you can put. So in adults, when we do FEM or FEM-JAG, actually, for venous ECMO, you put the big cannula in the groin and the small cannula in the neck. In children, less than, and my rule is 15 kilos, it's the other way around, because you can put a huge cannula in the neck because the head is big, and you cannot put a big cannula in the groin, so you reverse the circuit. So that's just a trick that you need to remember. In less than 15 kilos, I would say.
Okay.
Between 10 to 15 kilos. Anything less than 10 kilos, and don't even bother. Just do VA ECMO, and that's it from the neck. Right. Okay, so indication for cardiac support. and mass. Indications for cardiac support. So the indications for cardiac support are usually post-cardiotomy, which is the most common indications. Bridge to transplant, post-heart transplantation, mainly for primary graft failure, chronic cardiomyopathy as a bridge to longer MCS or bridge to decision, and peri-procedure support for high-risk percutaneous cardiac interventions, mainly in adolescents, not in neonates or small children. So for cardiogenic shock, severe cardiac failure due to almost any cause, arrhythmia, sepsis, drug overdose, myocarditis, pulmonary embolism, you can name it. As long as there's cardiac depression in patient in cardiogenic shock, there's an indication for ECMO. For severe respiratory failure with good cardiac function, but unable to do VV ECMO, mainly in neonates. So meconium aspiration, pneumonia, persistent pulmonary hypertension of newborn, acute respiratory distress syndrome. Congested diaphragmatic hernia is a very common indication to put patients on VA ECMO for repairability purposes. So components of an ECMO circuit are basically cannulas, which are equal to blood vessels, pumps, which is an equal to a heart, and a membrane oxygenator, which is an equivalent of a lung. And the ECMO is a very simple circuit. Basically, it's cannulas that are coming out and returning blood in. The blood comes out of the patient. There is you give heparin, you give fluids. There's a pump that pumps the blood that's coming from the venous system in through the oxygenator, and the pump is needed here because the oxygenator needs some for the gradient to happen. The heat exchanger is then the oxygenation and happens here, and then CO2 removal through the oxygenator through the heat exchanger, which returns the blood in a normal body temperature, and back to the patient. Now there are some circuits that have no pump, which are very special for pure respiratory failure, but they depend on the patient circulation. So you need to have normal right ventricular pressures and pumping, and they depend on venous gradients. But the general ECMO components are this. For peripheral cannulation, you can do VA ECMO through the neck in a neonate. You can do VV ECMO through the neck in an adult using a single cannula. This is an Avalon cannula, which basically has 2 ports. It's like a dialysis catheter, just bigger and longer. That drains blood out of one port, goes to the ECMO machine and returns it to a separate port that's opens on the side and directs it to the tricuspid valve. Or you can do VA through the groin. Central cannulation, as you guys all know it, I'm sure that you've guys seen it in adult or pediatric. You go through the chest and you cover the chest with an Esmer membrane or just a transparent membrane, whatever you have. And this is the big difference between central and peripheral. Central is the risk of bleeding is higher, and mediastinitis is higher. Here, the risk of thrombosis, the risk of not achieving full flow. And please remember, if you do VA ECMO peripherally, you have to think the leg is an organ. It has blood supply. It has other muscles that can die. So always think of the leg as a separate organ. You can wait for reperfusing the leg up to 6 hours, but always remember that your VA cannula that's going through the groin, even in a child, this is a child, needs support. And this can be done either cut down, open, or percutaneous based on the experience of the operator. The complications of ECMO, I think of them as either device related or patient related. So device related cannula, tubing, plastic, so they can wrong size, bleeding, malposition, clotting. The reservoir, which is not the big one, is inadequate return on air embolism, pump failure, oxygenator thrombosis, failing oxygenator, heat exchanger. You can have sepsis and from the heat exchanger because of bacteria. Patient-related, they can be systematic, renal, hematological, cardiovascular, neurological, or pulmonary. The most common ones are, the most feared ones are either intracranial bleeding or hemolysis and coagulopathy, but others are important too. Now, things to remember. So 20 to 30% of patients who undergo VA ECMO will get myocardial stunning. A heart that does not eject will dilate even at 200% of flow. But why? Does anyone know why? Okay, so a heart that does not eject still
Competitive
gets
flow.
blood back into it. No, it's not competitive flow. It's
Okay.
distension, not. So it distends.
Because
it has, the blood has.
there is still flow going into the left atrium, so the LV is still going to fill, and when you're at full flow, the aortic valve will be closed. So you have nothing. There is no vent draining the left side, so you will still get LV dilatation.
Yeah, so that's true. So there are mainly bronchial and direct aortic vessels that drain directly into the heart that cannot be bypassed by the ECMO, and the LV will distend slowly but surely. So the heart that does not eject means that the heart that the valve is closed, the aortic valve is closed, and the atrium and the ventricle will distend eventually. And then you are actually making everything worse by having myocardial stretch, subendocardial ischemia. The coronary sinus also gets blood flow because the coronaries are still getting blood through the ECMO. So the left distends and the right distends. And so that I actually making the patient worse not checking that. So you have to always, at least within the first 6 hours, not directly, but within 6 hours, do an echo and make sure that your heart is ejecting. Now, if your heart is ejecting on the arterial trace, and you have a pulse pressure of 20 millimeter mercury, then your heart is ejection. But if the line is flat, the pulse pressure is very narrow, then you have to think about, do I have to insert a vent or start some inotropes to make this heart eject? Always check your LV dilatation. Always, always, always. Within the first 6 to 12 hours minimum, and even earlier if there is zero ejection within the first 3 hours. High BP on ECMO is very bad. So the target map should be between 50 to 60, maybe up to 70 if the parameters are normalizing. So lactate is coming down, pH is normal, mixed venous saturation is within acceptable ranges. Avoid volume overload. This is a very bad thing. I know eventually for the first 6 to 24 hours, you need to give them volume for their physiology to adapt to the new physiology. But then after 24 hours, you have to give volume based on what you need. And have an early fluid removal strategy. That's very important. So start Lasix infusion, you start CRRT, you restrict fluids, accept higher venous pressures on the ECMO. You have to do something about it. For peripheral ECMO, aortic valve have to be competent. Otherwise, you will be in big trouble. If you have any evidence of AI, moderate mainly, or severe, then VA ECMO is a useless exercise because you are just pushing blood back into the LV. Please remember that the leg needs blood too. Try to insert this perfusion canal as soon as possible. I'm sure we are all cardiac surgeons. We need to know at least how to do a cut down to the femoral to get the superficial femoral artery. Now, some of us know how to use ultrasound and get the superficial femoral artery, but this is a niche that not a lot of us know how unless you get proper training. For peripheral ECMO, do not oversize your cannula, venous occlusion and limb edema or vascular complication. So you have to talk to your perfusionist and tell them, how much do you need to flow cardiac output of 2 to 2.25. So if they tell you, okay, they need a 17 arterial and a 21 venous, okay, good enough. And there is always room to discuss this. They cannot just keep opening stuff for you without you talking to them. Because at the end of the day, you are the one who's dealing with the complications. Avoid overflowing, which will increase the afterload. So if the cardiac output that this patient needs is 4 liters, 4 liters, even 3.5, that's fine. You are trying to help the heart, you are not trying to take over the function of the heart. So cardiac output of 2.5 to 4 liters per minute, or an index of 2 to 3 liter per minute per meter square is more than enough. Initially, you want high flows to remove the lactate, but then you can decrease. And you will be surprised. Some patients within 6 hours, you can go down to 2.5 liters per minute, and that's more than enough for them. For central ECMO, this does not apply. You can give as much flow as 6 liters if you want. There's nothing wrong here. But this is mainly for peripheral ECMO. So we'll talk about single ventricle ECMO. So a child with single ventricle defect is born with a heart that has only one ventricle, as you guys all know. And these are just different types of single ventricle physiologies. And the surgical history is very busy. From 1699, the first single ventricle case was described, all the way to Fontan, who developed his procedure in 1971. And we'll skip the case because of the time. So this is just a landmark study about comparison of shunt types in Norwood procedure versus single ventricle lesions, and the transplantation-free survival of 12 months after randomization was higher with the RV2PA conduit, which is the Sano shunt, compared to a modified VT shunt. And that changed the practice a little bit, but still people are more advocating RV2PA conduits because of the hemodynamic stability that they have after surgery. Now, modified VT shunt, when it's done right and the patient is stable, have better survival, but it depends. I know that King Faisal Specialist Hospital in Jeddah are very Sano advocates. So indication for cardiac ECMO association with LSUGAD. So mainly for cardiac failure. So mainly hypotension despite maximum dose of 2 inotropes, low cardiac output syndrome, low cardiac output with mixed venous that is very low, high central venous pressures, the oxygen saturation less than 50%, low cardiac output. This is very important for you guys to know, especially for the people who are sitting the exam, because you can be asked what are the indications for ECMO in a single ventricle patient post stage 1 Norwood. So it's very important to know what is the configuration. Is it a BT shunt or a Sano? Because it depends on the ECMO configuration, and management will depend on the shunt type. So when you do ECMO for a patient with BT shunt, and if you do it through the neck or directly through the central cannulation, you have to remember that your BT shunt is within your ECMO circuit. So you're actually sometimes overflowing your shunt and congesting your lung. If you have Sano, then that does not apply because you are actually bypassing the heart and draining the heart out. So the risk here is not overflow, but thrombosis of the shunt. So that's important to know what type of shunt you have because the management will change. So for a BT shunt, some people will accept overflow, or some people will go in while they're doing the ECMO and put a clip on the shunt to decrease the flow, increase the pressure in the shunt and decrease the flow in it. For a Sano, here you want ejection. You want the heart to eject. Why? Because when it's ejecting, it means that there is flow inside the Sano, and the risk of thrombosis is less. And you will accept some overflow. Just increase your flow in the ECMO. So that's why it's important to know which type of shunt you have. In a Sano, I will not aim for a full cardiac output override by the ECMO. I will actually allow the heart to eject and decrease my venous return. For a VT shunt, I will go and partially clip the shunt. So again, with the BT shunt, the slower PVR, ECMO flow will be directed towards the lungs. You can clip the shunt or wrap it with a snare or with a umbilical tape, partially occluded. Is the solution to increase the flow to 200 ml per kg? that's an option, but you'll overflow your lung. For an RV to PA conduit, you have to allow the heart to eject. This is the message. And accept some overflow to your lungs. Usually SANOs are very stable. They usually don't require ECMO. If they require ECMO, then there's a problem with the procedure, or the decision to go for Norwood was not right. So for stage 2, again, it's very important because that's a Glen. Alhamdulillah, it has low incidence of need for ECMO. Mortality with ECMO on a BCPC is quite high. So 50% of them will die on ECMO. Survival to hospital discharge with BCPC on ECMO is only 41%. Here the question is that you have to assure that you have adequate venous drainage. No obstruction, so single cannula through the BCPC. If you have some obstruction, then you need 2 cannulas. So the 2 cannula technique, basically you put a cannula in the IVC and the cannula in the BCPC and bypass the heart. It's not enough just to drain the BCPC. It is enough to drain only the IVC, because you most likely will have a VSD and a large ASD. Then whatever is coming back from the head through the lungs, you'll go back to the left atrium and drain. So if you want to do only peripheral, VA ECMO, you can do femoral. You have to do femoral venous. But before you go into ECMO, you have to rule out why they are needing ECMO. Is the Glen pressure too high? The heart, there's kinking, there's coronary compression. It's important to know why they have to go on ECMO. For stage 3, early is very low incidence, but high mortality, and late the incidence needs ECMO varies based on the cause of failure, and the mortality is less, but still high. For stage 3, you have to ensure adequate venous return. So you can do either direct arterial cannulation or Fontan circuit cannulation, or both, depending on what you want to how do you want to relieve the heart. And some people give back the circulation into the aorta or into the gland itself, based on if you need respiratory support, or in the Fontan circuit itself, or so it depends on you VA or VV. So if you're doing VV for Fontan, you can drain from the Fontan circuit and bring it back into the pulmonaries. Plus cure VV ECMO, but that's unfortunately requires midline stenotomy. For cardiac failure, lots of people, at least that's what we did in Australia, we cannulated the Fontan circuit for venous return and directly into the aorta, or peripheral VA ECMO. To avoid stasis in the Fontan circulation, that's the most important. You have to change from VA to VAV. So what does that mean? So you insert another circuit if you think that stasis is an issue into the Fontan circulation itself, by improving flow into the pulmonaries. So why CPR is useless in Fontan patients? Because there is no subpulmonic pumping chamber. So by doing CPR in a Fontan patient, you are not moving blood into the pulmonary circulation. But when you do CPR, you're compressing the heart. The heart is disconnected from the lungs. So there's whatever you're pumping is actually pumping blood through the Fontan circuit into the abdomen, not back into the lungs, because the intra-abdominal pressure is lower. So things to remember. Mortality is very high, unfortunately, in VA ECMO, but it's not as bad as people think. There is always some chance of survival. This is what I'm saying. So for neonatal, for pulmonary, 73% survival. Cardiac is only 42%. eCPR is almost equal to cardiac in neonates. In pediatric, survival is less, but it's acceptable. In adult, survival in pulmonary is improving. Cardiac is still bad, but it's acceptable. And eCPR is still quite bad. Again, ECMO is a balance between You know, it's a team effort, not just a surgeon and intensivist. It's actually a very big team effort of ECMO specialists, mechanical ventilator, antibiotic, rehab. And again, people have to remember that the glass is half full, not half empty. It doesn't matter if the glass is half full, empty, or half full, but be grateful that you have a glass. If every 2 patients, 1 survives, at least there is 1 survivor. Right, we'll go quickly through mechanical support. I don't know if Dr. Abdul is here or not.
معك يا دكتور هاني.
معلش دكتور عبد الرؤوف بس 10 دقائق واعطيك.
لا enjoying lecture ماشي.
طيب شكرا. طيب heart failure in children, basically there is modified risk heart failure classification for children. So it's class 1 asymptomatic, class 2 mild tachypnea, class 3 marked tachypnea and diaphoresis, and class 4 is symptomatic, such as tachypnea retraction. This is a bit different than adults, but you guys have just to remember that there is a different classification. Now, indication for MCS is mainly for heart failure and refractory medical therapy. But before that, you have to remember that all residual lesions that can be surgically corrected should be excluded and repaired before embarking on a mechanical security support for a child. So what's special about children is that they grow, so the device will never stay with them forever. They have somatic growth, so the chest is small, but it will get bigger. And pulsatility is very important, especially for children less than the age of 5 years, mainly for brain development. The evolution of that has been through a very tremendous change from a huge 1.1 kilo device that cannot be, and it can only be externally implanted into some intracardiac, and now the newest generations of intracorporeal devices. This is the HeartMate 2, HeartMate 3, the HVAD, which is HeartWave, which is not in the market anymore. But the devices are getting smaller. So in children, you can have minimal interest in MCS in general for multiple reasons: complexity, small population, return of investment, and other reasons that are not necessarily for you guys to know. But in 2004, there was the National Heart and Lung Blood Institute Pediatric Support Program that was initiated. The first device that was very popularized at that time was the micro med DeBakey VAD child. It was implantable, mobilization and rehabilitation was easy. Long-term support up to 6 months. Mainly, it was limited for 5 to 16 years of age, and implantation was very difficult in smaller children. And it was non-pulsatile axial flow. The Burn Heart, which is the most commonly used device in children, is developed in 2006. It's multiple sizes. You can go from 50 cc pump all the way to 280 pumps. It's paracorporeal, unfortunately, so the pump is extracorporeal, so the device is outside of the body. Only the cannulas are inside the patient. And it has the longest support in the literature for children. But it unfortunately high incidence of stroke and need for hospital. The patient needs to stay in the hospital. They cannot be discharged home. And the council is large. The only device that's approved for neonates up to full adolescent from 2.5 kilos to 60 kilos. So this is a very versatile device, and it's very easy to implant. This is a real pictures from patients that I done with during my training. So this is a BiVAD or Berlin heart. As you guys can see, the pump is extracorporeal. What is going into the patient is basically just cannulas. Patients can be extubated. This is the same baby. This baby is this baby. Extubated, fed, grow. The cannula size does not matter any that much. If the baby grows enough that they need more cardiac output, you can change these with conscious sedation in the OR. You just disconnect the cannulas from the connectors and connect them to the upgraded device. And you can do physio. They can do whatever they want. This is a picture from the real children also of the patient that we did. So the experience in X-Core is growing and it's improving. Outcomes are getting much better. Unfortunately, there are not too many studies in the world for these cases, but it's getting better. Jarvik is a small device. The mini Jarvik is at the size of the AAA battery, AA battery, but it has some pulsatility. But the biggest advantage is the high incidence of stroke, and not too many implants in children. No data yet, although I know that King Faisal Specialist Hospital in Riyadh are doing a study with European centers and planning to implant this device. They're still in development, so PediaFlow VAD, PD pump, and PVAD, but nothing out. For adolescent, between the weight of 30 to 60, the HeartMate 3 can be implanted, and the HVAD, the smallest child that have been implanted as HVAD was 19 kilos. But unfortunately, this is out of market now. I know Riyadh they've done some cases already with the HeartMate 3 in children, Dr. Faraz Khalil maybe. So the differences are minimal. They're the smallest implanted in 19.1 kilo, and for the HVAD is 13.8 kilos. And they're very comparable. The HeartMate 3 is a bit larger in size, but they are very comparable devices. This is too much detail. So transplantation in children, quickly. So the indication for transplant are very important in children. You guys have to know them. Need for ongoing intravenous inotropic support, complex congenital heart disease that is not amenable to conventional surgical repair or palliation, progressive deterioration of ventricular function, malignant arrhythmias, progressive pulmonary hypertension, growth failure, and acceptable poor quality of life. It's mainly for children. The problem with children is the donor pool is very low. Social constraints, chronic immunosuppression, failure rate is high, complications rate is high, and ethical consideration in pediatric transplant. This is a very hot subject, but beyond the scope here. The ISHLT registry of transplant shows that pediatric transplant is actually plateauing in the US and Europe because of the reasons that we just mentioned. It's mainly for cardiomyopathy is the most common cause, followed by, but only for congenital heart disease is mainly for neonates. And retransplantation is as the child grows, the heart will fail and it will need another heart or other modality. For ECMO, pre-transplant is mainly for diabetic cardiomyopathy. Congenital heart disease rarely require ECMO before transplant. As you guys can see, the survival is not that great. So for less than 1 year is 22 years survival. For 1 to 5 is 18. For 6 to 10 is 14, and for 11 to 17 is 13.1. So that's the problem with pediatric transplant. Survival is not great. So if you use mechanical support ECMO on VAD or the total artificial heart versus VAD, the survival is very poor before transplant. And then these are the predictors for poor survival after transplantation. So transplantation era, obviously, because of changes in immunosuppression. Diagnosis other than dilated cardiomyopathy, ventilator pre-operatively, congenital heart disease versus dilated cardiomyopathy. So dilated cardiomyopathy do well, actually. Diagnosis of Retex versus dilated cardiomyopathy, pre-transplantation versus the cardiomyopathy, and dialysis pre-transplant. The biggest program in the country and King Faisal Specialist Hospital, and they've done great work. They have done lots of heart and lung transplantations, mainly in children. Now there are multiple centers in the country, but all of them are mainly in Riyadh. The special complications of heart transplantation are mainly rejection, retransplantation, cardiac allograft vasculopathy, post-transplant lymphoproliferative disorder, and psychological disorders. And CAV is basically circumferential. It's not coronary artery disease that people think. It's actually intimal hyperplasia due to the immunosuppression. So it's weird. These are very typical lesions. When you cath these, and you do IBIS, it's the circumferential intimal hyperplasia. And unfortunately, this is something that will eventually happen to any heart. There's nothing to do about it except change the immunosuppression or require retransplantation. PTLD is a B cell proliferation induced by EBV infection. And that's why we look for EBV infection pre-transplantation. And it's a nasty disease. Thank you very much. Sorry for taking extra time. Okay, I'll leave the questions for later when we do the mock exam. So we took already too much time from Dr. Abdurraouf time. So if you guys don't mind, I will leave. If you have questions, you can ask me. Thank you. Dr. Rauf, I think you can start. Sorry for taking too much time of yours.
شكرا دكتور هاني. الشباب تبغون 5 minutes ولا break ولا we start immediately ولا؟
I think we can start, Doctor.
طيب. I want just to share just a minute. Do you see my screen?
Yes, Doctor.
السلام عليكم شباب. This lecture will be about cardiopulmonary bypass and pediatric cardiac surgery. It will be only the aspects of what is the difference that you face when you assume a pediatric cardiac surgical post rather than what you came through during your training. So it mainly talk about trends and updates in cardiopulmonary bypass setup in pediatric cardiac surgery. Well, I put it in form of clinical scenarios and question and answers, so it will be interactive. I will assume that you are familiar with the principle of cardiopulmonary bypass in adult cardiac surgery. So what are the differences that you face when you started to assume a pediatric cardiac surgical post regarding cardiopulmonary bypass in the preparation, in the priming, in the circuit size and design, in cannulation technique, conducting cardiopulmonary bypass, all these plus after cardiopulmonary bypass, especially MUF, which you don't do in adult, but we are doing it in many units as a routine in pediatrics, especially small babies. So we will talk all about all these in form of scenarios that we give you to you. 4 months old tetralogy fellows, what is abnormal in the X-ray? Can anybody answer?
Yes, I think this boot shape.
Yes. What else?
Pulmonary vascular marking.
Okay.
I'm not sure about the upper mediastinum. No thymus. I am not sure.
You are right. There is no thymus. So this is absent thymus. What gives you the syndrome? Sorry, I give it. So it gives you a clue about DiGeorge syndrome. Is that right?
Yes, 22Q11. Yes.
Okay. What's the incidence of DiGeorge in tetralogy fellows?
The commonest syndrome with the
Yeah, but what is the incidence in tetralogy effects?
well, I am not sure about percentage. Maybe
Is around
15.
Yeah, 15. Excellent, 15. And the truncus is around 35 and almost 50% in type B interruption. So it's not that interrupted aortic arch. So it's not, that is not that you will not see it. You will see it every year. You will see a couple of cases of DiGeorge syndrome if you work in a moderate or large site cardiac center. So what are the special pre-op consideration?
I think need irradiated blood for this patient.
Irradiated. Before that, you have to refer the patient to genetician and the immunologist to confirm the diagnosis. And then what is, why we give irradiated blood?
Because the RBCs affecting white blood cell, and then the host versus graft.
Yeah, but you made it quite fake answer for me.
Absence of T cell or abnormal T cell because the thymus is absent.
So
يعني يكون abnormal immunological response to RBC.
what happen if you give a normal blood transfusion?
So the white
Yeah.
The white
blood in the blood will
Yes.
will
And the
attack
donor blood.
when the donor blood will attack the patient.
Attack the patient if the patient having no cell, because regularly in the donor blood, the WBC, the white blood cells will be attacked by T cells of the recipient and kill them. This is what one of the causes of febrile reaction in the blood, if it is severe. Now, if you don't have a T cells to kill these WBCs in the donor blood, then the patient will start to develop this white blood cells will proliferate and start to attack the body. What is the incidence of severe immunological depression in DiGeorge is only 1%. But if it happened, the graft versus host reaction is mortality of 90%. So this is why we give a irradiated blood to kill what we call it WC in the donor blood. How to prevent it? We said the irradiated blood should be cytomegalovirus negative blood. What are the side effects of irradiated blood? The main side effect. Anybody knows? Is mainly hyperkalemia, because radiation will not affect only the WBC, also increase the hemolysis and the unit itself. So especially hyperkalemia you should consider in these cases. When to use blood in the brine? In low body weight or in low hematocrit hemodilution, we use it. This is why we don't use it in adult. It can be a whole blood, backed RBCs plus fresh frozen plasma. And what are the side effects of blood? We know it: infection, transfusion reaction, immunosuppression, alloimmunization, strain on blood supply in the unit itself. So all these are affecting are the side effects of using blood in the brine. But we have to use it especially in small babies. Cardiopulmonary bypass machine need to be primed with fluid and the air. So in adult, the priming is crystalloid. It's around 25 to 30% of patient whole blood. But in pediatric, it can be 200 to 300% of the patient own blood. This is why we use a blood in priming, especially in the small babies. What are the other priming solutions that we are using? Crystalloid, colloid solution. What other special consideration in DiGeorge syndrome that we need is hypocalcemia. Is that right?
Yes.
Priming solution additive, usually we give calcium, mannitol, and bicarbonate. I will not discuss what are the effect of is bicarbonate mandatory or not mandatory, and what do we need, what is it affecting the outcome is quite controversial. But anyway, calcium, most of in adults we don't use calcium, and we accept a mild hypocalcemia during starting cardiopulmonary bypass. This is why when you start cardiopulmonary bypass, you find the heart rate many times goes down because of hypocalcemia. Mannitol is added to increase the oncotic pressure. And another issue that we are using is in pediatric concentration, especially when you speak about adding bicarbonate, is alpha stat and pH stat. Anybody knows what is alpha stat and pH stat?
Yes, pH stat add CO2, normalize pH 7.4, and common use in pediatric.
Common use in pediatric.
Yes. With the deep hypothermic circulatory arrest.
Deep hypothermic circulatory. This is what you call about pH stat or alpha stat?
pH stat.
What is alpha stat?
Alpha stat for auto regulation. No need add CO2. pH around 7.4.
Assume that now that you are sitting on the perfusionist chair, and I ask you to what we call it, to give to use for me an alpha stat for the patient. Strategy. What do you do?
Look for temperature.
Yes.
Temperature.
Yeah.
Yes. Who is speaking? Muhammad.
ايوه في الالفا ستات you'll as the temperature goes down, the pH will tend to go up, so you will not change your CO2 to maintain the pH, while in pH stat you will add CO2 to bring the pH down to maintain a pH of 7.4.
Let's assume that we are at 28 degrees centigrade, and you are perfusionist sitting on the machine, and I give you an ABG. What's the difference in your reaction when it's alpha stat or pH stat? Anyway, the alpha stat strategy will maintain pH at 7.4 regardless what is the temperature. So when you have an acidosis, you correct. When you have too much alkalosis, you can decrease the sweep gas. This is what you do as a perfusionist. Now, when a pH stat is a temperature corrected measurement, and you have special normogram for this, and blood pH become increasingly alkaline as blood cools. To correct the alkalotic, as you said, we add what? CO2. To maintain a temperature corrected pH at 7.4. This is what we call a pH stat. So alpha stat is you don't look for temperature, you just correct what you have in the ABG. A pH stat, you have to correct it to the temperature according to the normogram by adding a CO2 on the sweep gas. A prime components, this is the classical prime component that you see is plasma light or any crystalloid or ringer lactate. And what are, I want to ask you a question. What are the types of ringer lactate do we have? What are the type of lactated ringer? Muhammad.
اللي عرفوه اللي هو الستاندرد لاكتيت رينجر لاكتيت اللي that used as يعني crystalloid يعني volume replacement اللي هو sodium is about 130 chloride is 10 sorry chloride is 110
Okay.
and it has lactate and a small amount of potassium in it as well.
Okay.
But about different types is the only one that I know of.
Anyway, the Ringer solution is either lactated or acetated. Is that right? Anyway, we will not stop at this point. And then albumin 25%. Why we add albumin, Muhammad? Anybody? Why do we add albumin?
To maintain the oncotic pressure with your priming solution.
And then, what is the effect, especially in small babies?
Because you want to prevent
beneficial effect. Yes. Go ahead.
You want to prevent tissue edema.
You want to counteract capillary leak syndrome and decrease the tissue. Excellent. What are the other beneficial effects of albumin on the circuit itself?
Decrease thrombosis in the line. Hemolysis.
How it decrease thrombosis? Excellent. It caught the tubes. Yes. We know that if you remember, if you do during your internship, you find some internist before giving insulin to the patient, they give albumin, flush the tube with albumin. Is that right?
Yes.
This is only to coat the tube, so that whatever insulin there will not go and attach to the tube itself. And the same thing, we coat the tube with albumin. Other coating is heparin and acrylic. Anyway, fresh whole blood. Most of the units you ask for fresh whole blood, or backed RBCs and fresh frozen plasma can be given. Calcium, we talked about it. What's the normal calcium level that we accept during cardiopulmonary bypass? Shabab.
We're looking for about I think 1.2 to 1.4.
This is the normal, Muhammad. We are talking about during the cardiopulmonary bypass. We accept a little bit of hypocalcemia, but not less than 0.6. More than that will be severe hypocalcemia. And then sodium bicarb, we talked about it. Heparin, we will come to the heparin. Lasix, cefazolin, and solimedrol. If you see, the only two things that you find in all units is heparin and antibiotics. Other is quite controversial. Some units still they don't use albumin. Sodium bicarb, many units they don't give. Many units they will accept hypocalcemia, and many units also they don't accept. They don't think that giving steroids is beneficial in priming components. But anyway, this is the classical priming component we in our own units and in many other units across the country. Case number, still we are in case number 1. After receiving heparin, 400 units per kg, ACT still 180 second. What we call this?
Heparin resistant.
Heparin resistance? Yes. Is there any other cause for it?
Antithrombin deficiency.
You are giving the same answer, Muhammad. Maybe you didn't give the proper dose.
Yes.
So you have to check your dose, especially, I remember the heparin can come in 5,000 per ml or 1,000 per ml. So you have to understand which type, you may not give the if the proper dose, or could be an expired. If you exclude this, then we talk about what you call heparin resistance. Check your heparin first of all, then ACT sample time. You may give heparin, but you take a sample time after 1 or 2 minutes. Then there is no time for heparin to get recirculated. So the ACT will not be a normal anyway. And if you are sure about that your heparin dose and the ACT sample time, then you are talking about heparin resistance. And the usual action we take, repeat the dose.
Maybe check for machine for ACT. You change
for
the
ACT machine. And we have 2 types of ACT machine. What is it? ACT test.
High range or low range?
What we call them?
I don't know.
Choline and I will leave this for you. Anyway, okay. Repeat the dose, and then if you are sure about heparin resistance, we give fresh frozen plasma. Why we give fresh frozen plasma? Why we have a heparin resistance anyway?
Because the FFP has antithrombin free, so you can. So the heparin resistance will be because of deficiency. So the FFP will replenish the yeah.
Okay, and if you have the antithrombin 3, you can give it without
directly. Yeah.
Okay, we give a concentrate. If still with resistance, then you give other anticoagulant like Horidi. To be frank with you, I saw it once in my life, maybe 4 years back, but I never used it before. But this is a situation that you can face. Unfortunately, most of the time, you recognize heparin resistance once you open the chest, so you have to act at that time. Preparation for cardiovascular bypass anticoagulation. Most commonly used heparin is a rapid onset, is easy reversibility, easily monitored with the ACT. Most of the units, they usually look for a target of more than 450. Let me ask you, what's the minimum ACT that you can go on cardiovascular bypass? Question.
400.
400? Why you say 400?
The best more 480. The saving.
Dr. Hani was talking about ECMO. How much the normal ACT in the ECMO?
150 to 200.
So why we accept here a higher?
Because you have a reservoir.
Because we are an open circuit. Is that right?
Yeah.
Yes.
Yeah.
Yeah. Anyway, the minimum ACT is quite different. Most of the units, they look for around 450 to go on cardiovascular bypass, but many assume that around 300, if you are forced to go cardiovascular bypass, is still safe for a while. Another advantage for heparin is a moderate therapeutic window, is not a narrow, and side effects of heparin is quite known for us, and few side effects. We know how to deal with it with antidote of heparin. Absolute contraindication of heparin is heparin-induced thrombocytopenia. When we see heparin-induced thrombocytopenia, Shabab? Classical. Anybody?
I'm patient with previous exposure to heparin.
Excellent. So, especially those who are on a heparin infusion before coming to cardiovascular bypass. How you diagnose it?
By serotonin and ELISA, enzyme linked.
Excellent. But before that, it's a thrombocytopenia, and if you have a patient on heparin infusion for more than 5 days, let's assume, and low platelet, then you should suspect the heparin hit or heparin-induced thrombocytopenia. Case number 2, 5 years old girl, partial AV canal with sickle cell anemia. What problem do you expect in this case?
Sickle cell crisis.
Sickle cell crisis. And what else?
Thrombosis as well.
Excellent.
Yes.
So you start from the night before. You have to prepare the patient. Is that right?
Yes.
First of all, you have to expect difficulty in cross-matching. Why?
Because patient have multiple exposure or multiple.
Excellent. So what they develop?
Antibodies.
Antibodies to what?
To the RBCs, to different types of antigens on RBCs.
Okay. Different antigens from ABO and RSS.
Yes.
Is that right?
Yeah.
And this is why sometimes you find difficulty in matching them, cross-matching them. Then you have to prepare for that to prevent sickle cell crisis. You should hydrate, exchange transfusion more than hemoglobin A more than 60%, and you have to avoid hypothermia during surgery as much as you can. Then the night before surgery, on-call resident told you that the patient is having cold agglutinins. What is cold agglutinins? Shabab.
Autoimmune hemolytic anemia.
Yes.
Antibody.
Antibodies, okay. Against what? Yalla.
Against RBCs that are triggered by a cold temperature. Below, I think, about 34 or 35.
About 34, 35?
Below 34 or 35, yeah.
We see cold agglutinin when really is very, very, very low temperature, below 20 most of the time, cold agglutinin. But what kind of cold agglutinin that we see? Shabab. We have monoclonal and polyclonal cold agglutinins. Monoclonal and neoplasm, especially lymphoreticular neoplasm. Polyclonal can come from acute infections such as mycoplasma, infectious mononucleosis, cytomegalovirus infection. So you could see it in pediatric. Typically, polyclonal cold agglutinin is typically transient. So we don't need to do anything. We just postpone the surgery for a couple of weeks. Now, the elective cardiac surgery should be postponed for several weeks, and emergency surgery, either we use a normothermia or a mild hypothermia. When you open, you didn't find an innominate vein in this particular patient. What is the causes?
Suspect left SVC, persistent left SVC.
Excellent. And what are the other cause?
Retroaortic.
Excellent. So we have two causes for not finding innominate vein, either left SVC or retroaortic. I will not ask about the incidence of retroaortic or left SVC, but how to manage left SVC before and if you discover it during cardiomyopathy bypass. Anybody can answer?
Yes.
Yeah.
Depend the type of surgery.
Okay.
Patient, for example, going cabbage, no need anything. Add you single two-stage cannula enough.
Okay.
And look for PC size If there is good SVC size and innominate size good, you can leave. If the innominate size small or absent, you can cannulate.
Okay, the direct cannulation.
Direct and retrograde cannula.
Or retrograde cannula. When you use the retrograde cannula? When you open the heart most of the time.
Yes,
Is that
put
right?
a snare. Yes, you can put a snare around coronary sinus and direct cannulate.
Okay. What are the snaring the coronary sinus? There are except for retrograde cannulation. What else you can use in snaring coronary sinus? Use it in what also? In pediatric. Go ahead. Not with the left SVC alone like this. Shabab. In retrograde cardioplegia, you can still give retrograde cardioplegia by snaring the mouth of coronary sinus and give a retrograde cardioplegia with a flexible cannula. Anyway, you can do a separate cannulation for left SVC. You can give a retrograde cannulation. You can snare the left SVC if it is small, or if you have a small innominate communicating between each other. Or if you have a short surgery, you can still snare it, but in this time, you should have a left anterior jugular cannula to monitor the pressure. 3 minutes after going on bump, the anesthetist told you that the NIRS is only 20%. What are the causes? Shabab.
Malpositioned arterial cannula could be one reason.
Okay.
Check the NIRS lead.
Before that?
Check the NIRS, the lead NIRS. Maybe not fixed very well.
If the I will give you a scenario that what? Yes, check what?
The bump flow also.
The bump flow and what else?
The pump oxygenation.
Excellent.
So
the first action you look to it, you look to your arterial tubes, at the same time ask your perfusionist what's the flow he's on. Now let's assume that the color is dark. What do you do?
Remove
check the oxygen source.
First of all, you restart ventilation if you are not on cross clamp. Okay, I let the blood eject, fill the heart to allow ejection, and then look why there is a dark blood coming from the pump. What are the causes of having a trouble?
Oxygenator maybe.
Excellent.
Oxygenator.
What else?
The source of the oxygen itself.
Excellent. Either maybe not connected.
Yeah.
And what else? Or what else?
Sweep connection.
Gas blender sometimes is defective, so you have to look for it. Sweep gas connections and flow. Oxygenator, central oxygen supply. Sometimes it's from central oxygen supply. It's stopped. So if all these can be causes that you see a dark blood in your tubing. So if you have a pink blood coming to the tube and the flow is normal, then you look to what Muhammad said, that you check your cannula position and NIRS attachment to the forehead of the baby. Again, you change the oxygenators. I want to ask you, what kind of oxygenator do we have?
Membranous oxygenator.
Yeah. What kind?
Whole fiber.
Most of the time, this time is what kind of oxygenator is available?
Whole fiber.
Okay. Whole fiber or hollow fibers or what?
Hollow fiber.
Okay.
And
Is
I
there
think
any relation between the oxygenator types and body weight? معلش هذا technical question.
I think yes.
So usually you have three what we call sets of oxygenator. Those oxygenators which work on units up to 10 to 15 kg, and then in the mid-range, and then after that adult. Most of the time you will not find them in one company, because many companies they don't develop a mid-range oxygenator. So you have to keep this in your mind. Usually oxygenator come with heat exchanger and arterial line filter in the same unit, and as you see it. Okay. Usually you see that now this oxygenator is attached to the reservoir. It comes as a one unit. It can come as a separate. Sometimes you have a custom bag without oxygenator, or have custom bag with oxygenator, depending on your unit. You have to know this beforehand. 1 week, case number 3, 1 week baby presented with a shock status, and your cardiologist sent to you as a quiz this image. What do you see?
The George syndrome.
Maybe the George syndrome. What else?
Interruption seems.
Interruption. This look like what kind of interruption?
Type B.
Type B.
Excellent. Type B. So what are the cannulation strategies in interruption? I mean arterial mainly.
Proximal or distal, ascending and descending also.
Is how you do the descending aorta cannulation?
Cannulate the PA or the ductus.
The BA of the ductus. Ductus, not everybody is doing it. I saw it, but I don't like it because ductus is still fragile, especially in unit. But cannulating MBA, and usually very huge MBA, and direct the cannula toward the descending aorta, and snare both pulmonary arteries once you go on cardiopulmonary bypass. These are the types of, we will come to this, the type of arterial cannula, either wire enforced or one-piece arterial cannula, or one-piece vented arterial cannula. Usually, if you want to cannulate the descending aorta, you use a flexible wire enforced cannula. This is the way we do it. And myself, I snare the BDA after putting the cannula and descending aorta. It depends on your way of doing it, but we do double cannulation. Now, how you connect both arterial cannula to the pump? Yalla shabab.
Y connector. Use Y connector.
In the arterial.
Yes.
Some unit, for me, even many times, I don't use a Y connection. I keep it connected to the ascending aorta, and then use the what we call it, the cardioplegia line to perfuse the lower part of the body. And because we have a femoral line in these cases, we can monitor how much the pressure in the descending aorta. Special cannulation technique. What do you see this? Anybody can tell me what is this? Yalla Muhammad. Anybody? What is this? Yes, huge what?
Right atrium.
Right atrium.
Excellent. Why you said huge right atrium?
Because the white chest.
Yeah, it's what? It's cardiomegaly. What's the definition of cardiomegaly? Shabab.
The cardiac silhouette taking more than more than 60% of the diameter, the chest diameter.
It's just diameter. It's
Yeah.
just diameter. Excellent, excellent. This is a very good answer. We will debate about where you count the cardiac cell height, but anyway, this is a. But you said that it's a right atrium. Why is the right atrium?
Because it's يا عبد العزيز لو يبغى
عبد العزيز.
it's ايوه هو اللي قاله.
You can go.
Okay. يلا عبد العزيز. Because if you see cardiomegaly, most of the time it's affect the left side of the heart. Is that right?
Yes.
The left side of the chest X-ray. Now, if you see it wall to wall, then most of the time is affecting the right side, and most of the time affecting right atrium. So you are right. This is a congenital huge diverticulum. Now, what do you do in these cases?
You can do a right atrial reduction to decrease the size of the right atrium.
Regarding cannulation, special
Peripheral.
cannulation.
Peripheral cannulation, the best.
Excellent. I remember one case in one of the major hospital in Riyadh. The surgeon didn't thought about it, and he opened the chest and he tried to cannulate the right atrium, which was a cigarette paper thin, and rupture. Immediately, patient died. They couldn't save the patient. So most prepare the femoral venous line. And maybe even better for you to do a complete cannulation and then open the chest and go on bump before opening the pericardium. We say that mention three cases that femoral cannulation can be done in a virgin chest. This is one of them. What else?
Minimally invasive.
Excellent. What else?
Aortic dissection.
Aortic dissection, excellent. Again, I prefer to do a venous cannula and scimitar syndrome because of connection of the scimitar veins quite low in the IVC instead of direct cannulation of the IVC itself. But anyway, excellent answers. Special cannulation technique, 18 years old, 90 kg post-arterial switch, massive ascending aorta, severe AI, CT scan for the chest, so the heart is stuck to the, especially the lacombe is stuck to the mediastinum, the pulmonary arteries. At the same time, the femoral access was limited. So what you are going to do? Redo with the limited femoral access. Shabab.
You can use at this age, you could probably use the axillary artery for your arterial cannulation.
Axillary artery or subclavian artery for...
Or subclavian, yeah. And for the venous, you could probably use the jugular, at least for the SVC, until you enter the chest, and then you can cannulate the right atrium directly.
Excellent. Now, this is a hospital for 6 children, arterial cannulas. You should know what cannula beforehand, before going on bump, because most of the time, if you want to assume a congenital heart disease, most of the time, once you enter the room, the perfusionist will ask you what size of the cannulas. So you have to memorize it, keep it in your mind, know the body weight of the patient, and know the size of the arterial cannula that you use. If you get forced and the aorta is small, then can you use one size below and accept a little bit higher pressure. What's the drawback of higher pressure in the pump? Anyway, what's the acceptable arterial line pressure?
300.
300, okay. What's the drawback of higher pressure? Hi, Shabab.
Hemolysis.
Excellent.
Yeah.
It's increased hemolysis. Excellent. Then we come to a venous cannula. Most commonly used in pediatric, a right angle metal tip or plastic tip, depending on the company. And the vent we have either straight or L-shaped vent. You should know that, especially if you have intracardiac shunt or extracardiac shunt, around 30% of neonatal escalating blood may held within the suction system. So you have to have a good suction system, left ventricular vent in pediatric and infants. Again, this is normogram. You should have it. Venous cannula sizes depend on the flow, and also the venous line size depend on the flow itself. This is a body range, and let's come to case number 4. 37 years old, 34 years post-arterial fallus repair, came for BVR immediately after going on cardiopulmonary bypass. Heart is empty, but the low flow, high pressure arterial line. What are the causes? Unfortunately mentioned here.
Dissection.
Dissection. The most important. Why I said dissection in tetralogy fallets? Because of huge aorta. In conotruncal region, they usually can come later on with a very huge aorta. So you have to expect that the patient may go into dissection. 6-month-old complex AV canal. You went on pump. Nasal temperature 28 after starting cooling, but rectal temperature 34. What are the causes? يلا شباب.
Check the probe in place. Rectal. Check the probe.
Excellent. What else? I told you that you already ligated the PDA. What else?
Aortic obstruction.
Excellent. Aortic obstruction, either coarctation or iatrogenic from ligating the PDA. It's not uncommon. You may face it one time in your life, so you have to expect it. Either misplaced probe or obstruction. Now we finally know all your components of cardiopulmonary bypass machine. I think this is quite familiar diagram for all of you. I will not go through it, but you should know from where it comes to you. When you ask for a high flow but the pressure is still low, you should suspect what? High flow and pump, but pressure is low.
Vasoplegia.
Vasoplegia, one of the causes. Excellent. What is other causes? Technical.
Your issue with the arterial line itself.
He's having a normal arterial pressure, line pressure is low. In fact, he's flowing fast. He's flowing 200 ml per kg, but the pressure is still 18, 20. You should ask him about to check his shunts. He may have an open shunt. So you have to he could easily detect it if he looked to venous reservoir and see the blood in the venous reservoir. But still, again, he should open shunt is not that uncommon, especially with a unexperienced perfusionist. So you have to expect it. Now, the tubing and cannula, I want to ask about venous-assisted venous drainage. Tubing diameters are very important. You have to know it. Tubing coating material, roller pump versus a centrifugal pump in pediatric, priming solution, crystalloid priming solution, or colloid priming solution. Anyway, synthetic colloid solution, we don't use it in the pediatric, especially after the FDA statement the last few years. Priming solution, we talked about bicarbonate, mannitol, and calcium, and other issues. We will come quickly through it. Tubing and cannula, nowadays, especially in the last 20 years, the people start to talk about miniaturized circuit. So smaller and shorter tubing, smaller essential cardiovascular bypass component, eliminating potentially component that can increase the surface areas like hemoconcentration, ultrafiltration, with additional suction lines and cell safer. This is the miniaturized pump that we talk about. Cardiovascular bypass venous retain either gravity siphonage or venous assisted vacuum assisted venous drainage with a negative of 20 to 60. Myself, I feel that less than minus 30, I mean minus 40 or minus 50 is not is still hazardous. So my maximum is maximum negative, I say, is minus 30. With venous assisted vacuum assisted venous drainage, you can use the shorter tubes, smaller tubes, and smaller venous cannulas can be used. When you have less than minus 30, millimeter mercury, then a bubble transgression when the vacuum accidentally reaches the oxygenator and pulls air bubbles into the blood itself, which can happen, especially in a closed circuit. AV loop options, you have different options. Anyway, you can discuss with your perfusionist and find the best for yourself and your design on table itself and the length of, especially the suction tubes length. Smaller tubes decrease the prime, but also increase the difference in the pressure itself. So vacuum assisted venous drainage is quite good for that. Now, tube coating material, we have heparin, albumin. This is you add in the priming. Acrylate tube coating material is there, and many studies about the coating material of the tubing or the whole circuit show decrease inflammatory response and decrease the post-op transfusion platelets, especially platelet transfusion. Custom back is a very important. You have to know, once you get assigned to be a pediatric cardiac surgeon, you have to know what custom back available in your department and what components of a custom back, because the definition of custom back quite elusive. It could be different from company to company and from hospital to hospital. So you have to know what is it to answer technically in the before going cardiopulmonary bypass or during cardiopulmonary bypass, what is the default came from or where is the problem started from, if you know your custom back quite well. This is the end of the lecture. Any question? Shabab.
Thank you, Doctor.
الله يحفظك.
دكتور عبد الرؤوف، بس بالنسبه لل alpha stat and pH stat up to what age يعني احنا في البيدياتريك كلاسيكلي ويقول لك ال pH stat، لكن up to what age would you use ال pH stat?
I never
that
use
is
it
during cooling.
First of all, we have to understand two things. Now, most of the people go into normothermia or mild hypothermia during cardiac bypass. And normal, we didn't talk about hematocrit because it will take I thought this is from a general cardiac bypass lecture. But nowadays we go into normothermia or mild hypothermia with a normal hematocrit or near normal hematocrit. I mean, hematocrit more than 30. In this case, you didn't need a what we call it a BH stat. But in general, we are using it in neonatal surgery once we go into deep hypothermia. Most of the unit they don't do normal these days. They don't bother themselves about what kind of BH stat or alpha stat they are using. Any other question? Okay. I will leave it.
شكرا جزيلا دكتور عبد الرؤوف، جزاك الله خير دكتور. excellent presentation. دكتور الوادعي معانا. اهلا دكتور عبد الله، الله يحييك. Thank you very much for agreeing to do this presentation to us. You guys are very important for us as pediatric cardiac surgeons because you guys save us most of the time. Thank you very much. Please share your screen and you can start your presentation.
السلام عليكم ورحمة الله وبركاته. الصوت واضح يا شباب؟
وعليكم السلام ورحمة الله وبركاته.
طيب أول شيء أشكرك هاني على الانفيتيشن و I congratulate you for this excellent course. Do you want to have 5 minutes break ولا should we just go ahead and continue? شباب تبون بريك ولا shall we start immediately؟
عبد الله.
نعم.
معك عبد الرؤوف يا سيدي.
نعم واكرم. هلا يا ابو محمد، يلا حيه.
الله يبقى عطنا 5 دقائق.
اي خلاص.
على الله.
يلا روحوا بس. We'll see you in 5 ها.
Last to see you guys at exactly 11 o'clock. Okay.
Good.
شكرا جزاكم الله خير. الو السلام عليكم. هل خلاص الساعة 11 ممكن نبدأ؟
جاهز إذا الشباب موجودين في
طيب نتأكد بس بس for your information دكتور عبد الله ال lecture is recorded. So if you're okay with that, it's okay.
Yeah.
If you want us not to record, tell us عشان we stop.
لا it's okay, go ahead. ما في مشكلة.
طيب I think we should start خلاص. بسم الله توكلنا على الله.
طيب بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. الله يوفقكم إن شاء الله في التريننج وفي الامتحانات. أشكرك هاني مرة ثانية على الاستضافة. I was asked to talk to you about pre-operative care in pediatric cardiac surgery. Maybe you will not see a lot of new things to you because you guys live in the ICU maybe as much as we do. But why the cardiothoracic surgeon need to be almost intensivist? Historically, as you all know, maybe 25 years ago, we as an intensivist not used to come to the ICU. It was all run by a cardiac surgeon. And hemodynamics issues and breathing are what mainly keep patient in the ICU. And you guys deal with these two things a lot during your surgery. And what we see in the ICU is actually it's a result of what you did in the OR and what patient had pre-op. The intensivist, and I'm one of them, we have our own limitations because we cannot do things that you guys can do and you can overcome, because either you know it better than what we do, or you can do it better than what we do. Because you guys in the OR, you have seen already the heart and lung by your eyes, and you can tell if things can be good or bad. In addition to everything we as intensivists can do, you guys can do more. Like you can open the chest in case if there is a problem, you can repair the residual lesion, you can start ECMO, you can stop surgical bleeding, which are things that affect the outcome in the ICU, and we as intensivists cannot do it. So you guys need to know that you are as important, or maybe more than the ICU physician in the management of the patient, even in the ICU itself. But you should remember that more ability or more power carry always more responsibility. Why PICU is different from adult ICU? Because as you all know, we deal with young patients. Their physiology is still developing, especially receptors. And as you know, the response to inotropes is different because of this, mainly this reason. The small size of patients that carry a high chance of complication and leaving a residual lesion behind. Most of the surgery need suturing inside the heart itself, and this by itself it change the anatomy and affect the function of the heart. Lungs are still developing, and as you will see in the coming slide, there is a significant cardiopulmonary interactions in that specific period of time. And most of the pediatric patients will require multiple surgeries, either stage surgery or multiple redos because of the nature of their diseases. We'll start with a few MCQ-based slides. We'll discuss this. Tim, maybe we'll not answer the question now, but we will come back to it after we finish the presentation. A 6-month-old boy admitted to the ICU post-tetralogy of fellow repair. His weight is 7 kilograms. He has no bleeding. His heart rate is 170, which is tachycardia, sinus. Blood pressure is low, 55/30 with MAP of 42. His CVB is 8. The pH is 7.32, PCO2 of 6, bicarb of 18, lactate of 5. He is receiving epinephrine 0.05. His hand and feet are not cold, so he's warm to examination. The best next step in management should be increase epinephrine to 0.1, add vasopressin, give bolus of normal saline, or open the chest. Can one volunteer answer this question?
I think this patient probably needs volume.
Right. Good. Will not comment. We'll go back to this question later on after we finish the discussion. طيب. After you give the volume, as Muhammad said, the CVB now is 15. His blood pressure is still low, 60/45. His heart rate is still high, 165, still sinus. You did echo and it showed good contractility, no residual RVOT obstruction. The urine output is only 1 cc per kg per hour. The best management approach now is start peritoneal dialysis, start Merinone and norepinephrine and wean epinephrine, add vasopressin to epinephrine, give blood transfusion. Any taker? يلا يا شباب.
Maybe
give blood transfusion.
Give blood transfusion. طيب. As we said, we will not comment on your answer. We'll go back to it and you will see what's the difference. طيب. Next, 2-year-old girl admitted after Fontan operation. She is awake and trying to pull the tube out, the 80 tube. Her heart rate is 140 sinus. Her blood pressure is 70/35, which is slightly low. Lactate is up to 4. The CVB is 20, which is the Fontan pressure. The pH is 7.31, PCO2 of 7, bicarb 17. She has no bleeding. The best approach is to sedate and paralyze. B, give volume. C, start epinephrine. D, extubate.
Extubate.
طيب. We'll come back again. طيب. 2-week-old baby admitted after aortopulmonary shunt اللي يسمونها PT shunt, والآن most of people change to central shunt. The heart rate is 160, blood pressure 90/45. The saturation is 89%. The lactate is up to 4. pH slightly acidotic, 7.34. PCO2 5, bicarb 20. The mechanical ventilatory setting is FiO2 21%, which is room air, PEEP of 5, and respiratory rate of 25. The true statement: he is stable and can be weaned to extubate. He needs adjustment of mechanical ventilation to wash more CO2. He has low cardiac output state, and he need to start systemic vasodilator soon. He need to increase FiO2 and start nitric oxide. This is PT shunt with these numbers. What do you think?
B.
Sorry, B.
Yeah.
من boy.
B, yes.
B من boy. He need adjustment to mechanical ventilation towards CO2. طيب. We'll come back to this if يصل. طيب. Fifth question. BT shunt is surgically created connection between systemic artery and pulmonary artery as a first stage of palliation for a single ventricle. Which of the following is false? So they are all true except one. It's done mainly to maintain reliable blood flow till the second stage, and sometimes it's done to help hypoplastic pulmonary artery to grow. Expected saturation after BT preferably more than 85%. Mostly done in the first few weeks of life. Patient after BT shunt need to receive either aspirin or warfarin to keep shunt patent. We're looking for a false statement. So which one is false?
B.
B. طيب. Bidirectional shunt, cavopulmonary shunt, or what we call Glenn shunt, is the second stage of palliative surgery for a single ventricle heart, which is false. The same thing. It is the connection of the superior vena cava to the pulmonary artery. B, the saturation after Glenn after Glenn shunt is mostly 80 to 90. C, it's usually delayed till 6 months of age, only for the pulmonary artery to grow, even if the pulmonary resistance is high. Due to the passive flow circulation in the upper body, the patients need to be maintained on some form of anticoagulation. Which one is false?
C.
Sorry, Faisal?
C.
C. Okay. Like last MCQ-based slide. Regarding Fontan procedure or the total cavopulmonary shunt, all of the following are true except the same thing. It is the connection of the inferior vena cava to the pulmonary artery. The saturation usually more than 90%. It is completely passive circulation on the right side, so the patient need anticoagulation. The patients after Fontan procedure do better if their single ventricle is anatomically right rather than anatomically left ventricle. Which one is false?
B.
Sorry?
B.
B. Okay. طيب, we'll go back to this question later on, but we'll go over a few slides. Maybe it's too many slides, but we'll try to see as much as we can. So I will take you through a journey, what we do in the ICU since we receive the patients or since we know about the patient coming from OR. So we need to know something about the patient before he arrived to us. The weight, for example, it's very important for us in pediatric ICU because we need to prepare appropriate bed, because the bed can be crib, can be a regular adult size bed. So we need all this information, though it sounds silly, but it's important for us. You cannot resuscitate a 1-week-old baby in an adult bed. You have to have a small bed. So these things are important to us. So we need to know the patient demographic to start preparing the patient's concentration and also the code sheet. We need to know the diagnosis so we can prepare few things that might be needed. For example, if the patient known to have pulmonary hypertension, we need to prepare nitric oxide for this crisis. We usually contact the OR. If they don't do, usually they call us, but if not, we will contact them to check about the stability of the patient, how much he's on inotropes, if he's on ECMO, if there is a BD dialysis catheter, how much inotropes he's on, and if he needs blood product or not. When the team comes from OR, unfortunately, sometimes they don't come all together. There is always somebody is missing in the team, but we like to see the anesthesia and the cardiac surgeon comes together to give us the handover. So usually we talk to the anesthesia first. We like to have adequate number, not too much and not too few. So usually one intensivist, one primary nurse, and 2 helper nurse, and 1 RT, in addition to intensivist, to anesthesia and a cardiac surgeon. Usually we give the anesthesia chance to report to the RT first, so he give him the handover for the airway, the size of the tube, difficulty of intubation, and lung dynamics. Then the anesthesia should start talking loudly so everybody can know the lines in the patient, what's running in each line, tubes, chest tube, BD fully, and how much drain from each one. Last time sedation was given to the patients and paralysis given, last blood gas and lactate, last ACT and protamine dose. And you will be surprised during the trip from the moving patient from the table to the ICU, a lot of things change, and you will be surprised as a surgeon. You left the patient stable, but this trip, short trip from OR to the ICU, sometimes change the physiology of the patient, and he will come to the ICU very sick. We need to know amount of blood lost, amount of blood product given, what inotropes and vasopressor he's on, and in case of the bleeding, if anything was given to the patient in the OR, factors and blood product. If there was an arrhythmia in the OR, we need to know about it and what medication was given, was there any cardioversion or pacemaker used. Then it's time for the surgeon to shine. So usually we like to know the detail of the procedure done by the surgeon, the length of the bypass, cross clamp, and if there was circulatory arrest, the degree of hypothermia, material used, if you use the mechanical valve or you use the patch, we need to know about these things because patient might need to be on certain medication for these materials. Any complication happened in the OR, any anticipated problems. For example, you surgeon, so the lung is bad, so you can tell us, well, I am expecting the lung to be difficult to ventilate, so that will help us in managing the patient. And if there is a TEE done, we need to know about the result. And what's the acceptable saturation? Because you guys might have done a surgery and you left a shunt inside the heart, and with that shunt, the blood will be shunting right to left, so we will accept low saturation. It's good if we know about this, so we can accept low saturation instead of keep pushing the FiO2 up. We'll go all back to the patient after we receive the anesthesia and surgeon report. We need to keep an eye on the patient hemodynamics all the time. The RT should fix the tube after the X-ray. The nurse should quickly check all lines, content, and status of each line, and make sure all drains are in closed system and hooked to the appropriate container. And you will be facing during your training or in your practice one of those silly cardiac arrest because the chest tube drain was not connected very well, or there was no suction connected to the patient. Myself, I have seen one patient arrested after coming from R just because the chest tube was not connected to the suction, unfortunately. Make sure there is no bleeding outside the collecting tubes and they are all patent, vital signs and acceptable for the patient age and disease. If pacemaker dependent, we need to check the leads and battery. We do a thorough examination. We check the head with the fontanelle tense, if there is a bleeding, or the breast if he's hypovolemic. We check for pupil. Fixed dilated pupil is most of the time very, very bad sign. And we need all to know about it to stop sedation and assist the patient. Pinpoint just maybe over sedated. In pediatric, you will be faced with unequal pupil size, and that can be bad if it is in somebody above neonatal age. But in neonate, sometimes we see it unequal size of pupil, which is okay. I know you guys use a lot of NIRS in the OR, and it's helpful, proven to be effective and predict cerebral saturation. However, in the ICU, it fails many times to show benefit in terms of mortality. This is one of the paper that talks about this one, because patient in the ICU is more awake than in the OR, so we can assess his CNS way before the saturation tell us about it. We need to measure the hemodynamics accurately in the ICU. We use our clinical examination, check the perfusion. We looked at the heart rate, how it is, from where it comes, if there is variability or not, patient-based or not. We do ECG as soon as possible to rule out arrhythmia, especially in case of junctional ectopic tachycardia. Sinus tachycardia is common because the patient comes from ICU, from OR, although they receive a lot of blood, but intravascularly they are depleted, they are in pain, they are inflamed. Sometimes tachycardia is needed to compensate for the low stroke volume in the pediatric patient because, you know, their stroke volume is lower than the expected, so they compensate with tachycardia. So you do not need to treat every single tachycardia. Any tachycardia that's not variable and no P wave should be diagnosed and treated, because if you lose the atrial kick, you're losing around 20% of the cardiac output. JET is the most common arrhythmia that we see in pediatric ICU, commonly post-lesion-like tough repair, causes by many things like pain, inotropes, fever, electrolytes. So we need to fix these things. If not working, we need to overdrive pacing arterially. We slow the rhythm by digoxin, and sometimes we need to treat the rhythm by amiodarone. There is other way of treating JET if it's difficult, like ECMO in extreme cases. What's unique about pediatric ICU that you guys don't see in adult is the single ventricle heart, which we will spend more time than biventricular heart in this review. So this is the normal heart, as you know it better than I do. And this is, can somebody tell me what's the diagnosis here? What is this heart?
Hypoplastic left heart.
Hypoplastic.
Very good. Very good. This is the hypoplastic left heart syndrome, which is the extreme form of congenital heart disease. As you can see, there is no mitral, no LV, and no aortic valve. The aortic ascending aorta is very small. And to fix this one, you have to do radical repair. We call it Norwood, where you transect the pulmonary artery, use the pulmonary trunk as an ascending aorta, in addition to a patch augmentation. So we try to fix the arch and add a shunt between the systemic artery and the pulmonary artery. This is one of the shunt that's used, the famous modified blalactosic shunt, but some people use a shunt from the RV to the pulmonary, as you know it, we call it Sinus shunt sometimes. Anyway, this is stage 1, very difficult in OR for surgeon, lots of suturing, and RV is the systemic ventricle pushing blood for both pulmonary and systemic circulation. This is the second stage, which is Glenn, as you all know. We transect this VC from the junction to the RA, and we connect it to the pulmonary artery. So all the blood from the head and neck and the arms goes directly to the lung without pumping chamber, which need a good lung to work. The third stage of palliation of single ventricle is the Fontan procedure. And all of these three stages have went through modification over the last 50 or 60 years. As you know better than I do, this is the most commonly used now, which is extracardiac Fontan, connection from the IVC to the pulmonary artery using a tube, mainly Gore-Tex tube. We don't go through the heart in most of the case nowadays. Some surgeons still using it because it has some complication in the future. We need to talk about cardiopulmonary interaction, especially in single ventricle heart. So the PEEP, which is a positive end expiratory pressure that's applied during mechanical ventilation, affect the heart. The PEEP effect on the right heart is bad because it decreases the preload, because as you all know that intrathoracic pressure affect the venous return. So if you have a PEEP, you will decrease the preload, which affect the cardiac output. PEEP also increase the afterload, which is also not good for the right heart lesion, including the single ventricle palliation, Glenn and Fontan. So the cardiac output from the right side is not good if you are applying PEEP. However, on the other side, PEEP is good for the left heart problems because it increases the preload by pushing blood from the lung to the left atrium. It decreases the left-sided afterload because it improves the contractility of the LV. So it helps improving the cardiac output from the left side. So if you have to balance between these two interaction and know your patient better, is he a right side problem or left side problem? In pediatric cardiac surgery, we do a lot of connection. The major one is that we talked about is the BT shunt, where we create a shunt between the systemic and the pulmonary artery. So the ventricle will pump out to the two circulation, and we need to balance the circulation. We call it balanced circulation in single ventricle heart. This is a cartoon diagram of a single ventricle heart. This is the single ventricle. Pump blood through the outflow, which is mainly aorta or new aorta after construction, and the blood either go to the left side to the lung or the right side, which is the body. So you can imagine if you have 100% saturated blood of a 4 liter coming from the lung mixed with a 50% saturated 4 liter from the systemic venous return, they mixed and form 8 liter. If you mix 100 with 50, you will have 75%. Pumped goes from the atrium to the single ventricle, then get out from the single ventricle as a 4 liter to the systemic circulation saturating 75, and a 4 liter to the pulmonary circulation saturating 75. And this is the best scenario you can imagine, where you have exactly 1-to-1 QB to QS. So 4 liter to the systemic and 4 liter to the pulmonary circulation. Your saturation is 75. Your pH is normal. Blood pressure is good, and lactate is good, and urine output is also good, and the QB/QS is 1-to-1. This is perfect balanced circulation that you dream to have in the ICU, but it does not always happen. So what happened is that sometimes you have a RT or a doctor or a nurse who don't know this balanced circulation and delegate patient. So they will think that 75 is not enough. So what they will do, they will give oxygen to the patient. So what happened, they vasodilate the pulmonary circulation. So instead of 4 liter going to the left side, 5 liter goes to the pulmonary circulation. 5 liter of 100% mixed with a 3 liter of 50%, you will end up having 8 liter of 85%. So you will have 8 liter of 8%, 85% saturated blood going to the aorta, and you will measure a saturation in the patient systemic saturation of 85. If you don't know, you think this is good, but it's not good actually, because your blood pressure will be low, because you have lower cardiac output to the systemic circulation. You will start to have acidosis in pH. Lactate is going to go up. Urine output will go down, and now your QB/QS is 2-to-1. And now you can imagine the MCQ question that we asked for before. So don't be happy if you have high saturation in a single ventricle, because it's time to act. If you don't act and you keep giving oxygen to the patient, more blood will go to the lung because the resistance is lower. You have 6 liter instead of 4 liter. And this 6 liter is 85% saturated. It will come out as a 6 liter 100% saturation mixed with a 2 liter only of 50% saturated mixed venous saturation. And you will have 8 liter of 90% saturation comes out, and you will have 90% saturated blood in the systemic circulation. And this is not good at all. Patient will be in the verge of cardiac arrest. Your blood pressure will be very low, 45/25, pH is more acidotic, lactate is higher, urine output is lower, and QPQS is 3:1 at least. So you have to act, otherwise the patient will crash and you will not be able maybe to revive him. So now you can figure out the problem with that patient we saw in the MCQs. If your saturation is above 80, maybe 85 in a single ventricle, you are in trouble. You have to do something about that, otherwise you will lose your patients. That was a stage 1, which is PT shunt. If a patient survives and goes to Glenn and Fontaine, you have to know that Glenn and Fontaine share concept that there is no pulmonary ventricle. Their blood flow to the lung is passive. So both are very sensitive to intrathoracic pressure. This is a nice study done by Dr. Reddington, where he did not measure actually, he did a Doppler ultrasound to the pulmonary blood flow. As you can see in the top left figure, this is patient spontaneously breathing, and as you can see, the flow to the lung is good and constant. He asked the patient to do Valsalva, where he creates a high intrathoracic pressure, and you can see how low is the cardiac output to the lung. That's why intrathoracic hypertension is not good for Glenn and Fontaine. The same group, Dr. Reddington and his colleagues, they did positive pressure ventilation, and you can see the cardiac output to the lung. The QP was only 2. They changed patient from positive pressure to negative pressure ventilation. The cardiac output went to 3.5. Then they put the patient again to positive pressure ventilation, and the cardiac output went down. So they even they confirm it with negative pressure ventilation with higher negative pressure, and they found that the cardiac output improved with negative pressure ventilation, which is the spontaneous breathing if you cannot do it mechanically. That's why the MCQ case that we presented with Fontaine patient who was agitated and his cardiac output looks low, the best way is to extubate him, because you will improve the cardiac output, you will wash the lactate, and the patient will be better off mechanical ventilation. So in summary of this concept, that pulmonary blood flow in Glenn and Fontaine is particularly sensitive to change in intrathoracic pressure. It increases with lower intrathoracic pressure and decreases with higher intrathoracic pressure. So ideally, post-operative management for these 2 lesions, Glenn and Fontaine, and maybe some cases of TOF, when they have RV restrictive physiology, is to early extubate those patients. So what about fluid in the ICU? We use a lot of fluid resuscitation, and we mainly use normal saline or albumin. I know most of people believe in albumin. However, if you look at the studies that done comparing albumin to a normal saline, this is one of them in the New England Journal of Medicine long time ago. Actually, there was no difference between normal saline and 5% albumin in terms of outcome after 28 days. So don't be very strict about using albumin. In fact, maybe normal saline is better in some patients if they have no inflammatory response. One with the volume that we use a lot in the ICU, cardiac ICU specifically, is the blood. People love to give blood, and people think that the blood can fix everything. And this is a study from New England in 1999 called the TRIC study. They looked at adult patients in all ICUs, general and cardiac. They divide them in 2 groups, restrictive strategy, where they transfuse them only when the hemoglobin go below 7, and liberal if the hemoglobin go below 9, and they found there is no difference in the 2 groups. The same scenario was done on pediatric patient, published after 8 years in 2007 in the same New England Journal of Medicine. They looked at more than 600 patients in multi-center study format, RCT, and they divide them in the same group, 7 gram per deciliter versus 9, and they found in stable critically ill children, hemoglobin threshold of 7 per deciliter for RP transfusion can decrease transfusion requirement without increasing adverse outcome. Not only that, but the same principle was applied in single ventricle patients, where they divided the Glenn and Fontaine patient to 2 groups. One group will get transfusion if their hemoglobin drop below 9, and the other group, they will get transfusion if their hemoglobin drop below 13. And there was no significant difference in the outcome between the two groups. Not only that, but they found also in blood transfusion is associated with prolonged duration of mechanical ventilation in an infant undergoing reparative cardiac surgery. So we should be we should think a lot before we give blood to those patients in the cardiac ICU, especially if they are stable, not bleeding. So what can we do instead of giving blood? We can minimize phlebotomy, and this is one of the many studies that showed if you do a lot of blood work that, and I am sure you notice that in many ICUs, they do a lot of routine blood work. Sometimes they do CBC 3 times a day or 2 times a day. I don't know what is going to add if you know the white blood cell 3 times a day. It's not going to change a lot. So we should think about minimizing the phlebotomy. You should remove art line immediately if you don't need it. Let's look at this study that was published a long time ago. They looked at the patient who have art line in the ICU. They found they have up to 44% increase for blood volume sent to the lab in comparing to those patients who don't have an art line. So if you don't need the art line, take it out, because everybody feels safe and easy to do blood work if there is an art line. Give oxygen to patient even if they are anemic, because in one study it was equal that if you give 100% oxygen to patient, it's equal if you give him 3 grams per deciliter of blood transfusion. I like this quote. It says, blood transfusion is like marriage. It should not be taken upon lightly or unadvisedly or wantonly, but more often is absolutely necessary. So think a lot before you go to transfusion. We need to monitor patient in the cardiac ICU because a lot of things can go wrong. We care about good cardiac output, which is the result of heart rate and stroke volume. The stroke volume, as you all know, affected by preload, contractility, and afterload. Most of our patients in the ICU are hypotensive, but they are hypotensive because of different region, and you have to treat each one of them differently. So if they are hypovolemic, like the first patient we talked about in TOF, post-TOF, they will have low CVB for their disease, low cardiac index, and high systemic vascular resistance. So you don't need to give them vasoconstrictor or inotrope. What you need first is to give them volume, because they are hypovolemic. They could be hypotensive because they are in cardiogenic shock, which means that their CVB is high, their cardiac index is low, and they have high SVR. So in those patients, you need to give them inotropes, and if failed, you can use other machines like intra-aortic balloon if they are adult. The other type of patient, if they are hypotensive in the cardiac ICU, they could be vasogenic hypotensive. So their CVB will be low, their cardiac index will be low, and they have low systemic vascular resistance. On those patients, it's time to use medication, vasopressor, mainly because their contractility usually is normal. So you vasoconstrict rather than give them volume or inotropes. Not only that, but also the number we see in the monitor is not actually accurate. They are affected by many things, and you can see a long list of factors affecting the accuracy of CVB reading and blood pressure monitoring. And that's why we don't only depend on numbers, we go to other measurements. One of the most important is the mixed venous saturation. As you can see here, the right one is the normal cardiac output, and you can see the blue part of the bar is the cardiac output when it's good. The patient will take the blue part, which is 25% of the cardiac output, or whatever he needs. So if the cardiac output drop to half, as in this case, the tissue will continue to take the same amount. But that same amount, when there is a 4 liter, for example, was only 1 liter of cardiac output. So you will have mixed venous saturation going back to the heart of 75%. However, if the cardiac output goes down to 2 liter, the tissue will continue to take 1 liter, which is 50% of the cardiac output. That's why you will have a mixed venous saturation that's low. So mixed venous saturation is a very good indicator for the cardiac output because it tells you a lot more than the number on the monitor about the tissue perfusion. Lactate is also good because it's happen if there is insufficient perfusion to meet metabolic demand. As cardiac output improve, the anaerobic metabolism should decrease and the lactate level should decrease to normal. However, lactate also can be affected by many things. One of the major things is the kidney function. CVB is a good indicator. However, it's affected by many things like obstruction in the great veins, mechanical ventilation, tricuspid regurgitation, some vasoconstriction to the preload of the right ventricle. So CVB is good, but it's not always very accurate in some cases. Not only that, but some cases you need high CVB, higher than the normal. For example, restrictive physiology like restrictive cardiomyopathy, hypertrophic cardiomyopathy, restrictive pericarditis, or a single ventricle heart like a Glenn and Fontaine. The normal CVB is 5 ± 3. These 3 diseases or 4 diseases, they need CVB most of the time in the mid-teens, 13, 14, 15 to maintain a good cardiac output. And to know what is the good CVB for patients, it's better to learn the ultrasound where you look at the IVC collapsibility and it will tell you if the patient needs more fluid or not. This concept I'm trying to preach over the last few years because I believe it's important, which I call permissive hypotension in ICU management of patients, all patients, including cardiac. Because if you guys look at what we use now for our target to achieve in terms of blood pressure, we are using actually more than what we should. And this is one of the good studies actually that were published a long time ago. I looked at the analysis of the evidence for lower limit of systolic mean arterial blood pressure. And what they found that when they developed their estimate, very scientific and detailed way of calculating the lower acceptable normal MAP value for reference, they found that the estimated lower limits of systolic are lower than the currently used to define hypotension. So what we define as hypotension is actually more than what we should accept. We should accept lower than these numbers. And we'll talk about that more in detail. For example, this is a figure that's used as a lower systolic blood pressure from 3 different international bodies, Advanced Pediatric Advanced Life Support, Brain Trauma Foundation, and International Pediatric Sepsis Consensus Conference. So look at their definition of hypotension. For example, let's take neonate, 1 week to 1 month. Anything less than 60 is hypotension in pediatric advanced life support, less than 65 in trauma, and less than 80 in sepsis. So you can see the variability. So which one to choose? Do we need to go very conservative to 79, or we can be accepting 60 as our definition? So there is no consensus about what is the right definition of hypotension. More important than this number of blood pressure definition as hypotension is what happened at the tissue level. Because, you know, as we talked about mixed venous saturation, we care about what's the oxygen consumption rather than the number that we are getting on the monitor. Because if the consumption is high, that will be more accurate definition of low cardiac output rather than the exact number of the blood pressure that you're measuring in your monitor. And as you all know, the consumption of oxygen different from tissue to tissue. For example, the heart consume a lot of oxygen, while skin consume very little of oxygen that goes to these tissues. In the same line of trying to accept lower blood pressure, we have to remember that there is deleterious effect of inotropic therapy in the patient himself. We know that short-term the inotropes are good, but for long-term it increases the oxygen consumption. We know there is potentially harm effect of vasopressor agent for the same reason, and also the fluid administration that we think it's a benign thing. It's not actually. It might even deteriorate the cardiac output of the patient. So to avoid all these side effects of the medication that or therapy that you are using to fix the number of the blood pressure, maybe you should accept lower blood pressure and look for better assessment. So what we should aim is what we call adequate rather than normal cardiac output, where we have a good skin color, acceptable heart rate, capillary refill is good, reasonable urine output, change in acidosis toward normal, lactate level that's trending rather than absolute number, and improving mixed venous saturation. So if you have these things in control, even if you have lower blood pressure than what textbook says, you should accept that rather than pushing the patient to the limits by giving a lot of inotropes and volumes that he might get a negative side effect of this medication. This is ultrasound of the IVC, and you can see this patient, the IVC is fixed. It is not collapsing with the breathing, which means you cannot give more volume, because if you give more volume, this will negatively affect the patient rather than helping him. This patient, for example, as you can see, the contractility is good, but the atrium and the both right and left atrium are huge, which means that this is a restrictive physiology or restrictive cardiomyopathy. So he will need high CVB. Even if your CVB read 15, 16, and your cardiac output is low, you can give more volume because they are preload dependent. While this patient, as you can see, the left ventricle is weak, dilated, doesn't contract very well. And if this patient has normal CVB, blood pressure is still low, these patients are the ones who will need inotropes for a short period of time. While this one, you see this patient has a good contractility. This is hypertrophic heart. As you can see, the ventricle volume or the ventricle space collapsed completely. So the ejection fraction is like maybe 85 or 90%. But if this patient is still hypotensive, you give him volume, but you start vasopressor rather than inotropic support. So I like this analogy of spare tire in the ICU management. So if you're driving your car and you have puncture and you are using your spare tire, and you know that the spare tire is not as good the real one, so you cannot drive fast in those tires, and you should drive slow until you change it. So for sick patients in the ICU, aim for adequate cardiac output to perfuse important organs, even if your blood pressure, urine output, or your recap fill are not completely normal. But continue to reevaluate the patient and learn echo, because it will help you to choose the right management strategy for the patients. So I like this slide. We do a lot of things to our patients because we receive them when they are small babies, and they live with us until sometimes they die. We want them to have happy at the beginning, productive in the middle, and peaceful at the end of their life. However, it's not the end, not even the beginning of the end, but maybe the end of the beginning. Let's go back to the question that we asked in the beginning. So 6-month-old boy admitted to the ICU post-TOF repair. His weight is good. You know, tetralogy of Fallot repair is one of the few cardiac disease in pediatric that they don't have failure to thrive. They actually are good size, chubby, weight is good. So this patient has a good weight, bleeding, no bleeding, heart rate is tachycardic sinus, blood pressure is low, CVP is 8, pH is slightly low, so there is slight acidosis, PCO2 is 6, bicarb is 18, lactate 5, he's on epinephrine, he is warm to exam. So the next step in the management, Muhammad Gal, what did you say, Muhammad?
Give volume.
صح. The answer is give volume because this patient is a TOF. تعرفون مشكلة الTOF post op إيش يصير عندهم محمد؟
So they have a hypertrophic, especially RV.
Yeah. So their RV is having restrictive physiology. So this means that RV is still hypertrophied. The diastolic pressure of the RV is high. So you need high CVB to push the blood to the RV. So their RV doesn't relax well, but the contractility usually is very good. So even if the CVB is 8, which might be good for other disease, maybe it's not enough for tetralogy of Fallot in the first 24, 48, even 72 hours post-op. So the answer, as Mohammed said, is give volume. Not only 10, you can give up to actually 50, 10, then 10, then 10, as much as he needs. So for the same patient, we give volume. The CVB now is up to 15. Still, the patient is hypotensive, tachycardic, sinus. You did echo, you want to check, and you found the contractility is good. And there is no residual RVOT obstruction. Urine output is still low. So he's still in low cardiac output status. The best management approach is من اللي جاوب على السؤال هذا قبل شوي؟
أنا.
إيش قلت؟
قلت D, give blood transfusion.
طيب, why it's not true? Maybe it's true, but it's not the best. احنا قلنا the best management approach. So the patient is hypotensive. احنا قلنا ثلاث أشياء. You need a full tank. You need a good contractility. You need a good resistance. صح? No vasoplegia. So is this patient problem is in the first one tank حقه full ولا empty?
CVP is good.
So his tank is full. So it's not a problem of intravascular volume. Is his contractility is a problem?
No, good.
No, his echo showing good contractility. So you're left with the last one, which is vasoplegia. So maybe he's vasodilated, صح?
Yes, maybe C.
So
the answer C.
طيب, in specific, if anybody else, C will be good answer. بس ليش هذا it's not C? إيش كان محمد إيش قال عن السيناريو الأول? This is what? This is tough, صح?
Yes, hypertrophic.
Hypertrophic cardiomyopathy. So the answer is
B.
B, صح, B. لأن الhypertrophic RV better relax with Merinone, and norepinephrine is good for you as a vasopressor. So epinephrine is not a good choice for tetralogy of Fallot. Actually, norepinephrine is good as a vasoconstrictor, and Merinone is good as the lysotropic effect. So it helps to relax the RV. So usually in tetralogy of Fallot, if you fill them up, the contractility is good. It's good to combine Merinone with norepinephrine to help relaxing the RV and vasoconstricting the systemic circulation. ليش norepinephrine or even sometimes vasopressin is good in tetralogy post-op? Because coronary perfusion. To the coronary perfusion is the difference between diastolic blood pressure and the EDB, صح? So the EDB in the RV post-tetralogy is high. So if you leave the diastolic pressure to go low, you compromise the coronary perfusion. So it's good to use norepinephrine rather than epinephrine. In addition, epinephrine theoretically is more arrhythmogenic. The patient might go to JET just because of epinephrine, more oxygen consumption. So norepinephrine is good and better than epinephrine in this case. طيب. اللي بعدها الفونتان قلنا 2 years had Fontan. She came awake and trying to pull the tube out. Her heart rate is high, tachycardic. Blood pressure is lower side. Lactate is slightly high. CVB is high, 20. pH is 7.31. So there is some acidosis, both respiratory and metabolic acidosis. She's not bleeding. So the best approach is to
extubate. D.
Extubate. Very good. CVB is high. Why the CVB is high? 20. Because she's awake. She is creating high intrathoracic pressure. And the blood زي ما قلنا is passive circulation to the lung. So any pressure in the lung لما يبكي ولا يكح ولا زي كذا متضايق, the CVB will go high. أول ما تشيل التube out, the CVB will go down to 14, 13, and your cardiac output will improve. You will see the pH is going to normal, lactate is clearing, blood pressure will be better. So always Glenn and Fontan, if you can extubate them in the OR, actually extubate them in the OR better than bringing them intubated to the ICU. طيب. Next, 2 weeks old baby admitted after BT shunt. The heart rate is slightly high, 160. Blood pressure is high, 90 over 45. Saturation is high, 89. Lactate is in the higher side, 4. pH is slightly acidotic. pH 7.34. PCO2 5, bicarb 20. The mechanical ventilation is in room air, low PEEP and low rate. So the true statement is, بعد ما استمعنا المحاضرة ايش رايكم يا شباب؟ ايش الإجابة الصحيحة هنا؟ Is he stable?
He's over circulating his lung.
Good. So he is in the verge of cardiac arrest. He's over circulating. كم الكيو بي كيو اس يا محمد هنا؟
Here it would be at least 3-to-1.
Exactly. تذكروا الأرقام هذه. 75 saturation is 1-to-1. 85 saturation is 2:1, 90 saturation is 3:1 in single ventricle BT shunt heart. So this patient is over shunting. So you're seeing a high saturation and high blood pressure, and what drives the blood pressure now is not, most likely is not the vasodilatation of the pulmonary circulation, is the hypertension of the systemic circulation. So what you need to do, Mohammed, is if I2 is only 1%, you need to vasodilate the patient. So what's the answer? C. So he is in low cardiac output state. وقلنا ليش؟ لأن the saturation is high, lactate is high, pH start to be low, and his urine output most likely low. So he need a vasodilator. You bring the blood pressure down, you shift the blood flow from the lung to the systemic circulation. طيب. اللي بعده BT shunt is surgically created connection between systemic and pulmonary artery. The first stage of palliation, we are looking for false answer. It's done mainly to maintain reliable blood flow till the second stage, and sometimes to help hypoplastic pulmonary artery to grow. Yes or no? True.
The false B.
True. We are looking for false. So the false answer is B. صح. Expected saturation of BT shunt زي ما قلنا is not 85 and not good to be 85. The expected is between 70 and 80. And it's mostly done in the first week of life. Yes. Patient need anticoagulation. Yes. طيب. Glenn shunt we are looking for false answer. إيش الإجابة هنا الآن؟
B.
وشو؟ B من بوي. أحد عنده إجابة أخرى؟ كم expected Glenn saturation؟
80.
صح 80 to 90 حتى. Above, sometimes above 90 لو كان في كواشيما. لكن إيش اللي is not true in this؟ ايش رايك في
C? You can't do Glenn if the pulmonary resistance is high.
Yeah, هذا actually is more important, maybe as important or even more important than pulmonary artery size. لأن size you can do something about it. Into surgeon you can make it bigger, but you cannot do much about resistant. So we delay it to make sure that the pulmonary vascular resistance is low. It's not only the size; it's also the resistant in the lung. So the answer is C. Last but not least, the Frontal Procedure which is the total IVC to pulmonary artery. Which one is true? إيش الإجابة؟
D.
Sorry, we're looking for a false. All are true except one.
D. They do better if it's an LV rather than RV.
صحيح. Now we believe this. We see this. You will find one or two small study telling you that the RV is as good as LV, but in reality, if you have an RV as a systemic ventricle, it doesn't hold for a long time. وانتم تشوفونها حتى في LTGA patient, they fail with time. I think that was the last slide. الله يوفقكم. إذا في سؤال أو comment أو شيء, please go ahead.
طيب السلام عليكم دكتور عبد الله. Thank you very much. جزاك الله خير. محاضرة جميلة ومختصرة و to the point. الله يعطيك ألف عافية.
توفيق. الله يوفقكم يا شباب إن شاء الله تعالى. السلام عليكم ورحمة الله وبركاته.
وعليكم السلام ورحمة الله وبركاته. طيب guys, دكتور محمد حسن is with us. If you guys want to take just a 5-minute break. دكتور محمد, how are you? جزاك الله خير. شكرا. معلش أخرناك بس صارت في شوية لخبطة اليوم. يعطيك العافية. دكتور محمد.
شكل في مشكلة بالمايك لأنه المايك شغال بس ما في صوت.
ما نسمعك دكتور محمد.
السلام عليكم.
وعليكم السلام ورحمة الله وبركاته.
هل الصوت واضح؟
نعم ممتاز جزاك الله خير.
مشكور دكتور. كذا الصوت واضح؟
ممتاز.
طيب خلاص تاخذون 5 دقائق زي ما تفضلت؟
اي والله يا ريت. طيب بالنسبة بس مين اللي شباب بس بالنسبة للتسجيل لو سمحتوا بس توقفوا الريكوردينج. دكتور محمد بس طلب انه ما نسوي ريكوردينج الحين, هو حيعدل السلايدز بعدين يرسل لنا هي.
شور.
وقفوا برضو اللايف ستريم برضو وقفوا اسمه.
شور.
شكرا.